So welcome. Thank you for joining us. I'm Yolanda Colson, President of the American Association for Thoracic Surgery, and it's my pleasure to do the introduction and welcome you to the global webinar on guideline development. Why are we doing this? Because it's incredibly important to our specialty that we all become experts in how to manage and participate in guidelines. Clinical practice recommendation documents or guidelines, called CPD or CPG, are documents developed by content experts that include recommendations intended to optimize patient care. Many guidelines today, even from established societies and organizations, suffer from inadequacies in guideline development. These errors are often due to failure to equitably represent the various disciplines involved in care decisions, differences in data inclusion and interpretation, lack of transparency in recommendation synthesis and rating, and absence of a thorough external review process. These limitations have resulted in accusations of bias and politicalization of guidelines and has led to dubious levels of trust or frank distrust in a process meant to help guide patient care. Given the importance that clinical guidelines now carry in dictating access to various care options, government and third-party payer reimbursement, and legal examples of standard of care, it is critically important that all cardiothoracic surgeons, and particularly those involved in guideline development, are highly skilled in the interpretation and development of clinical guidelines that impact our specialty globally. The purpose of this multi-societal webinar is to provide information on best practice standards that are objective, scientifically valid, and consistent, with the goal of teaching cardiothoracic surgeons the necessary skills to actively participate and to assure the development of trustworthy clinical practice guidelines. It is our hope that these will ultimately improve healthcare decision-making, quality, and outcome. Thank you. I hope you enjoy today's webinar.
Clinical practice documents or guidelines are not a compilation of specialty opinions. Rather, they are a set of recommendations by content experts intended to optimize patient care. These must be informed by a systematic review of evidence and an assessment of the benefits and harms of alternative care options.
Clinical practice documents should not result in a one-size-fits-all approach to patient care. They should rather offer an evaluation of the quality of the relevant scientific literature and an assessment of the likely benefits and harms of a particular treatment. Such information and guidance will enable healthcare providers to proceed thoughtfully in selecting the best care for a unique patient based on his or her situation, comorbidities, and preferences.
According to the Institutes of Medicine 2011 document, Clinical Practice Guidelines We Can Trust, clinical practice documents must be based on a systematic review of the existing evidence, be developed by a knowledgeable multidisciplinary panel of experts and representatives from key affected groups. They should consider important patient subgroups and patient preferences as appropriate, and be based on an explicit and transparent process that minimizes distortions, biases, and conflicts of interest. They should provide a clear explanation of the logical relationships between alternative care options and health outcomes, and provide ratings of both the quality of evidence and the strength of recommendations. And finally, be reconsidered and revised as appropriate when important new evidence warrants modifications of recommendations.
The importance and impact of clinical practice documents are aimed at directly facilitating individual clinician and patient decision-making by helping to interpret the outcomes of clinical trials as they relate to specific patient scenarios. However, these same documents are often used in non-clinical care settings and referenced by non-medical stakeholders with medical, legal, insurance, care access, and healthcare policy financial implications. It is critical that these unforeseen consequences are also considered in the drafting of guidelines and care recommendations. Thank you very much.
Cardiothoracic surgery has recently experienced increasing difficulty in creating meaningful and actionable documents, which not only guide care delivery for our patients, but also inform our healthcare colleagues and payers as to the best practices concerning a particular cardiothoracic disease. The process of creating multi-society and multi-specialty evidence-based documents or guidelines that provide these clinical roadmaps is difficult. The AATS, ASCVTS, EACTS, ESTS, LACIS, and the STS have all experienced similar challenges in developing such guidelines. To that end, these cardiothoracic surgical societies have worked together to create guidance for cardiothoracic surgeons who are asked to serve on committees charged with the development of such guidelines. We are sharing the resulting joint webinar to outline the basic principles of guideline creation. In addition, we also wish to remind anyone who is asked to participate on a guideline writing committee or process to be sure that the critical principles are being met as one considers before agreeing to participate. Specifically, to create valid guidelines based on the best medical evidence, these major tenets must be met. Number one, the number of experts must be balanced from both surgical and medical disciplines. Two, the experts must be selected for their expertise and ability to champion the data interpretation in an impartial manner. Three, the data must be of the highest quality, preferably randomized and adequately designed trials to support conclusions the studies were designed to answer, and not more. Four, data interpretation should be free from bias. Unless all of these tenets are respected and followed, the compromise process will unlikely result in a true, meaningful guideline. Our specialty remains committed to developing and outlining great care based on the best medical evidence available. However, if you find yourself being asked to develop a guideline that does not meet these tenets, we would respectfully ask that you contact your organizational leadership before joining such an endeavor so that our specialty can ensure that only the best clinical care documents are created for our patients.
So there are several types of clinical recommendation documents. The STS and AATS have produced guidelines on how to develop their guidelines in 2017, and EACTS did the same a little bit earlier in 2015. Now, the different types of documents that we can produce depend on the level of evidence available to base these recommendations on. In the North American documents, there are three main types: the clinical practice guidelines, where there's a sufficient evidence to develop a systematic review, expert consensus documents where it's not possible to do a systematic review, and white papers or expert opinions. On the European side, we have 5 types of documents with, again, clinical guidelines, expert consensus statements, technology reviews, and clinical statements from EACTS. And here's a summary of the main types of documents and their differences. Now, the next presentations will do a little bit deeper dive into each type of document, but you can see here that there are small methodological differences between each of these documents, even if they have the same name. For example, in clinical practice guidelines in North America, they are developed using the Institute of Medicine standards, In Europe, we use the PICOT systematic review and base the evidence on RCTs or robust non-RCT data. We see also that when there's little evidence available, we have different types of documents. At EACTS, we have technology reviews, which are focused on new treatments, new interventions, and are similar in their development to expert consensus statements and clinical statements, which are coming from the association. In the AATS and STS format, they're expert opinions and white papers for areas where there's less robust evidence that's available.
There have long existed a variety of clinical guideline documents that have served to aid clinicians in making appropriate decisions in the care of their patients. While often helpful, the methodology used by clinical experts to generate guideline recommendations have hardly been uniform, transparent, evidence-based, or free from bias. Noting the wide disparity in the rigor and quality of the processes behind the development of these documents, the Institute of Medicine was directed in 2008 to establish standards for clinical guideline development. The resulting IOM statement entitled Clinical Practice Guidelines We Can Trust was published in 2011. This monograph defined standard nomenclature and provided a framework and standards for clinical guideline development. The IOM report defined clinical practice guidelines as statements that include recommendations intended to optimize patient care that are informed by a systematic review of evidence and an assessment of the benefits and harms of alternative care options. Now, the IOM felt to be trustworthy, guidelines should be based on a reproducible, systematic review of the existing evidence, be developed by a knowledgeable, multidisciplinary panel of experts and representatives from key affected groups, consider important patient subgroups and patient preferences as appropriate, be based on an explicit and transparent process that minimizes distortions, biases, and conflicts of interest. Provide a clear explanation of the logical relationships between alternative care options and health outcomes, and importantly, provide ratings of both the quality of evidence and the strength of the proposed recommendations. Finally, guidelines should be reconsidered periodically and revised as appropriate when new evidence warrants modifications of their recommendations. Now, there are a variety of clinical practice statements. These may include clinical practice guidelines, expert consensus documents, and white papers that focus primarily on expert opinion. To be considered, a clinical practice guideline requires adherence to IOM standards, which we will review shortly, available comparative evidence to allow for a systematic review, and a perceived gap in care, which the clinical practice guideline will serve to narrow. If insufficient evidence is present for a comparative systematic review, yet opportunities to correct major gaps in care exist, then development of an expert consensus document is appropriate. Now, there are several standards as outlined by the IOM for clinical guideline development. First, complete transparency should be present throughout the entire process. There should be thoughtful composition of the multidisciplinary guideline development group with a focus on content expertise, key stakeholders, and diversity. There needs to be appropriate management of the inevitable conflicts of interest that arise. The guideline development needs to utilize a reproducible, proper, systematic review techniques. Once formulated, the guideline recommendations need to be separately considered regarding the level or quality of evidence and the strength or class of each recommendation, as per the displayed ACC-AHA table. Each recommendation needs to be carefully articulated in a standardized form to reflect the strength of the recommendation. Once completed, the guidelines should undergo an extensive review, including outside peer review. And then finally, the guidelines should allow for updating at regular intervals.
There are three types of documents based on the AATS-STS Joint Position Statement on Clinical Practice Documents. The type of document is determined by the quality of evidence associated with the topic of discussion, and the process of development of the three types of documents are different. Guidelines are suitable when there is robust comparative evidence and a systematic review is possible. On the other hand, expert consensus documents are typically designed to address areas where there is sparsity of high-level comparative evidence. But there's sufficient data that exists to reach a consensus and agreement among experts to make informed recommendations or suggestions about the treatments and clinical care. Finally, a white paper is appropriate when there is really little data to work with. There are usually reviews or opinions about new technologies and procedures or policy matters. In terms of structure and process, the latter, i.e., the white papers, are more like executive summaries or communique. But when it comes to guidelines and expert consensus documents, they have similarities in structure and process, but they also have differences. So in terms of structure, both guidelines and expert consensus documents have a diverse and balanced writing groups. The guidelines documents follow many aspects of the Institutes of Medicine specifications and includes experts in the development of the guidelines documents. Both expert consensus documents and guideline documents utilize a robust consensus building process, and the AATS and STS subscribe to a modified Delphi process that requires 80% participation in the voting by writing group members and a 75% threshold to reach a consensus. In addition, multiple rounds of voting may be necessary to reach that threshold. A class of recommendation and the level of evidence as modeled after the ACC and AHA guidelines is utilized by guidelines documents, but is not required for expert consensus documents where suggestions and statements suffice. A period of public comment is mandatory in the AATS-STS guideline development process and has been customary for expert consensus documents as well. And this differentiates it actually from the ACC-AHA guidelines. So to summarize, when you have sufficient quality evidence and consistency of reported outcomes, then a guideline document is the preferred pathway. Otherwise, expert consensus document may be more appropriate. But both guidelines and expert consensus documents have a robust review process of the available evidence, and both utilize a modified Delphi consensus process to formulate suggestions or recommendations. Thank you.
There are several types of clinical practice documents. These examples illustrate the ways EX and AATS and STS classify them. Clinical practice guidelines are always at the top of importance. Then come expert consensus documents. And finally, in rare situations, the association published clinical statements, position statements, or white papers all mean more or less the same. Clinical practice guidelines are formalized statements that include recommendations to create best practice and optimize patient care. This type of document should be developed when the sufficient data from randomized and non-randomized studies exist to support the proposed recommendation from the writing committee group. Expert consensus statements are opinion on a particular procedure, treatment, or process that generally is agreed upon as representing the current best practice for the particular topic. We use expert consensus statements to address issues with controversy, uncertainty in the absence of high quality evidence to help in guiding clinical decision. And finally, position statements assert the association position on a particular issue or topic. They are generally short, focused commentaries that could address clinical, economic, research, organizational, or other controversial matters impacting daily clinical practice. Irrespective of the document type, all must follow formal process, including systematic literature search, writing methodology, and anonymous voting if necessary. In this meta-analysis of guidelines from ACC and HA and ESC published between 2008 and 2018 and presented recently JAMA, we can see that less than 5% of recommendation in major cardiovascular society guidelines were supported by evidence from at least 2 randomized controlled trials. Despite thousands of research articles being published yearly, our gap in knowledge are significant. Therefore, another critical role of society documents is to acknowledge the gaps in knowledge and stimulate research to address questions of particular clinical importance. To summarize, work on clinical practice guidelines when there is a sufficient comparative evidence, preferably from prospective studies, to address the question of vital clinical importance. Develop expert consensus statements when comparative evidence is not sufficient to demonstrate the superiority of one technique or intervention over another. And finally, use position statements to present the society point of view on a clinical procedure, medical practice matter, or healthcare policy issue. Thank you. Now I'm going to talk about the systematic process overview for the development of clinical practice guidelines and other society documents. Every clinical practice guideline must be strictly developed using the formal development process. It starts with the project scope evaluation and approval from the governing bodies, including the specific domain, the Committee for Clinical Practice Guidelines or Research Evidence, and then a final approval from the Council or the Board of Directors. Then after, domain and CPG committee identify potential projects chair and task force members and ask them to complete the declaration of interest form for further evaluation. Once the review committee confirms that the submitted DOIs could not compromise the project's credibility, the writing committee members are invited to sign the terms of reference letter and the confidentiality agreement. After finalizing all of this paperwork, the project chairs could schedule the first kickoff meeting, during which all the members need to agree about the table of content, timelines, milestones, and the PICOT question for the initiation of systematic literature review process. The PICOT question should be formalized with the assistance of methodology for clinical practice guidelines, which could be an expert in biostatistics, clinical epidemiology, or both. Then, the search strategy and systematic literature search should be conducted with the assistance of biomedical specialists known as a medical librarian. The entire task force should take their role in the data extrapolation and development of summary of findings table and ask for independent reevaluation only for challenging scenarios. An independent research organization could also do this, but the cost is tremendously high, and only rare association and healthcare policymakers can afford this investment. Once the evidence is synthesized, the task force members should define specific recommendation using the suggested phrases to determine classes of recommendation, and then write supporting text for each proposed recommendation. Then after, anonymous voting should be performed using a modified Delphi system with at least 75% of threshold for approval of each specific recommendation. In case of voting failure, this process must be repeated until all the recommendations are voted on successfully. Every guideline should undergo anonymous external validation process under the society journal's lead. The document could be accepted for publication, release, and the presentation only after all reviewer concerns are addressed successfully. The guideline must be updated every 3 to 5 years or even earlier if necessary to remain helpful in modern clinical practice. Thank you.
So first of all, it is very important to define if there is a clear gap or need for a guideline. And how do we define the need? So this can be defined by societies, by expert members of the societies, giving input to the societies, suggesting a topic for guidelines. And then, as is going to be discussed in this webinar, it's important with intersocietal cooperation to avoid that similar societies produce similar guidelines at the same time, and even worse if we come up with different recommendations. And the clear gap can come from development of new treatment modalities, such as for lung cancer now, the development of immunotherapy. How is this going to affect the new treatment guidelines? This could be one example. And if there was recent substantial evidence that may be practice changing, for instance, in segmentectomy, we now have 2 large RCTs that has been awaited for more than 10 years, the JCOG trial and the CLGB trial. And in that sense, this can be the initiative to develop a guideline group when we expect this to be practice changing. And this can also be in a topic where there's a significant variety in practice, that this can be the incentive for a topic of a guideline. And very important, it must be patient-centric. So how much evidence and literature are there on the current topic? An initial systematic literature search is important to get an idea of the evidence in the area. And is there enough comparative evidence for a systematic review? For clinical practice guidelines, we need level A or level B evidence to come up with a guideline as such. If there is not this level of evidence and a scarcity of well-conducted randomized controlled trials, an expert consensus document may be another solution, or even a white paper expert opinion if there is a lack of evidence. Then defining the scope and begin the table of contact. So it's important to formulate the objectives and the clinical relevant questions in the PICOT format, patient intervention, comparison and outcome. And this should be done together with a librarian, and the systematic literature search should be performed in cooperation with a librarian professional search. It's important to beforehand to define inclusion and exclusion criteria for relevant publications to be included in the guideline. Thank you very much.
So it is important that appropriate and balanced representations of all stakeholders are assured. And balanced representatives are considered, that means there should be diversity in experience and perspective, for example, surgeons, medicals, nurses, or at least patient representatives, and methodical expertise, for example, clinicians or scientists. Do have different ideas about the point they are interested, and they might be coming from different areas of the world, so geographic diversity is important also, and of course, gender. You need to have juniors and seniors on board. They have different experience, they have different intention, why they are interested in these guidelines, and different time and support of all what they are doing. And nevertheless, you don't need also the aspects of university and high volume centers, but also from local and clinical experience and scientists. Junior representatives might have more time. At least they do have good career opportunities if they are involved in guidelines, but they need active senior mentors as co-commitment participants of the guideline, as if it is a very, very important guideline. But on the other hand, for intra-society guidelines, they might be the representatives on their own. Problems for them might be they don't have the time because they have to do clinical parts at the all. On the other hand, senior representatives have significant long-lasting experience and knowledge, but possibly influenced by personal experience, political experience, and might be declining real-world experience. That means balanced representation is something which needs to be done in multidisciplinary working groups. Their work must be transparent. They should be independent from outside influences like economical or political groups, and they have to have a mandate from the societies and the medical groups for whom they are nominated and represented.
So the first question that comes to mind is that, am I a content expert? And an expert is a person with special knowledge, expertise, and skills in a particular area of interest. A surgeon who has contributed to the field, clinical and research, with peer-reviewed publications, book chapters, leading authorship. To be invited to the guidelines is really an honor and an affirmation of the surgeon status as a validated researcher and clinician. The second question is, do I have any conflicts, financial and otherwise? And if the question is what to disclose, then you have to be able to disclose everything, including supporting travel, honorariums, consulting agreements, and royalties. And you have to disclose all financial and not financial relationships, and also these disclosures needs to be updated whenever any change occurs. It's very important to know that any new relationship is heavily discouraged during the duration of the project until the project is published. The most important of all is that you have to be transparent and disclose everything, even if you think that something is not relevant. The second question is, do I have the time to dedicate to the project? As a member of a guideline committee, an hour weekly is a team participation to report the progress is usually required, and this is based on my recent experience on the ACC and AHA guidelines on aortic disease. As a co-chair or a co-chair of a guideline committee, usually you require an additional hour per week to report the progress and to discuss and evaluate and review written sections. That means as a co-chair or as a chair, you need a total of 2 hours a week to be engaged on this effort. In addition, as a member, as well as a co-chair, you need to be able to deliver the requested sections of the project on time by reviewing the existing literature and the evidence-based material. Usually, the guideline document requires 2 years, approximately 2 years, for completion. The other question that comes to mind is, what unique experience can I bring into the table? And always you have to think about specific qualifications and the special skills, writing as well as verbal communication, which could help the other project members to improve the quality of information provided. And working in a multidisciplinary environment, You have to be able to collaborate and have the ability to lead other surgeons as well as within a multidisciplinary environment. The question also that comes is, who are you representing? The society, the surgeons, the field of practice, etc. One thing always to remember is that a clinical practice recommendation document or a guideline document is developed in collaboration with and endorsed by various societies, especially when we talk about multidisciplinary guideline document. A member of each society is selected to represent that society on the committee, and as a representative, you have to ensure that the beliefs of your society are adequately represented. During the review process and after voting, you need to be able to bring the concerns of your society, if any, to the chairs and the leaders of the project. And this step is extremely important. And of course, as we know, throughout the process will be different conflicts. These conflicts or concerns, for the scientific community's best interest and for the interest of our specialty and of our surgical community, these concerns need to be solved behind the scenes. It's very important always to remember what is the purpose of the guidelines and why all these concerns need to be solved behind the scenes. Because the purpose of these guidelines is to provide guidance to our colleagues how to serve our patients better. The other question that always comes is how many surgeons are on the writing group. So given that the guideline document is developed usually in collaboration with and endorsed by various societies, the equitable representation is a key to ensure the best evidence-based medical information provided. The chair and the co-chairs, they have the primary responsibility for the selection of the committee members and equitable surgical representation, which actually is very important. In addition, the chairs need to ensure diversity and inclusion of the writing committee and committee members. Now, the number of the authors could vary, and this really depending on the number of the societies represented. Based on the past documents, the number of the authors varied, can be from 13 to 26, and in a multidisciplinary document, equal representation of surgeons is extremely important.
When it comes to evidence synthesis and appraisal, it's important to look at the data set. Is it based on a representative population? Are the patients evaluated in the studies of appropriate disease extent and severity? For example, if you're looking at treatments for patients with 3-vessel coronary artery disease, were the incorporated trials based on patients with 3-vessel disease, or were they mostly patients with 2- and single-vessel disease? Was the design of the trials appropriate? And what was compared to what? You need to look at the intervention arm and make sure there's an appropriate control arm. What was the experience and the expertise of the surgeons and proceduralists involved in those trials? Because are those results reproducible by the average proceduralists and surgeons? Are the findings generalizable? And finally, it's important to look at the outcomes. Look at the pre-specified outcomes and definitions as published in the protocols of those trials. Beware of any last-minute changes. We're all familiar with the controversy surrounding the Excel trial, whereby the definition of a perioperative MI was changed in the 11th hour before the publication in the New England Journal of Medicine. Follow-up is critical. What is the completeness of follow-up? Was it imbalanced between treatment arms? And how long was the follow-up? We all know that, for example, CABG is a lifelong treatment, whereas PCI or medical therapy are less durable options in patients with severe three-vessel disease. Always look at missing data because they can impact the outcomes and the interpretation of the studies, and always look at the findings and recommendations in the context of real-world practice. Does it make sense? When it comes to reviewing the evidence, surgeons need to be systematic and methodical. They really need to look at everything, not just the main text, but look at the tables, look at the figures, associated legends and footnotes. Go with a fine comb through the supplemental material. A prime example is that recently 2 surgeons identified multiple mistakes in the supplementary material of the ischemia trial, and therefore challenged the robustness of the data and the trustworthiness of the data in terms of it being utilized, amongst other things, to downgrade the CABG recommendations in the 2021 ACC/AHA guidelines. Be on the lookout for discrepancies and inconsistencies. There are always cracks in evidence. How big are those cracks? Does the data presented actually support the summary evidence and recommendations? Examine all source documents. Pay attention to details. And when you're not sure, ask a trusted expert colleague. And remember, your professional associations are a great resource for expertise and help in that regard. Look for misinterpretations and misrepresentations of the data. Spin is more common than you think, unfortunately. Bias can come in different forms and shapes. However, the good news today is that surgeons are better prepared than ever before to look at, interpret the evidence and the data. When it comes to guidelines and recommendations, surgeons should trust but verify what's presented to them so that they could provide their patients with the best possible care. Thank you.
There are multiple types of conflict. Some of these are quite common. They include how the document is actually organized, whether you use sort of a disease-based or anatomy-based, or what I would call vertical versus horizontal organization. There can be conflict in terms of the content that's actually being incorporated. Very importantly, there can be conflict over the data interpretation. For example, things that are defined as non-inferior does not necessarily imply that the other thing is superior. Also, whenever data is interpreted in a manner other than the originally stated endpoints or the goal of that study, that may be actually a misuse of that primary source data, and this can lead to conflict. There can be disagreements regarding the actual guideline recommendations in terms of the level of recommendation, and also in terms of how to define that particular class of evidence. Remember, not every single piece of evidence is going to be a multi-center prospective randomized clinical trial. There can also be disagreements on the exact verbiage. There are recommended words to use, such as maybe or possibly or probably, but there can be disagreements on exactly what verbiage is being used. And then there can also be disagreements on whether or not to put information directly into an actual recommendation or to put it into the supplemental material as more of a commentary. So how do we try to resolve some of these conflicts? Well, please do not lose professionalism and the extremely valuable collegial collaboration that you've worked so hard to achieve. Definitely do not breach confidentiality, and try to avoid sidebars or subdivisions within a writing group. Efforts to lobby other members of the writing group to take your side of the equation. Also, this can be thought of for 2 different groups, whether you're a writing group member or you're the chair or vice chair of a writing group. So if you're a writing group member, when there is a conflict, discuss this with the chair of the writing group. but be sure to prepare a rationale and have definitive evidence supporting your side. In addition to highlighting the problem, always suggest a reasonable solution. Don't just present problems, present solutions as well. And then if you're the chair or the leader of a writing group, then what's really important is that the disagreement stays within the organization so that externally there is tremendous confidentiality, but internally you really should have a lot of transparency and document the issues. For the ACC/AHA guidelines, each of the guidelines will have a liaison, basically an individual who interacts directly with the overall oversight committee for all guidelines. That individual can be very helpful in solving potential disagreements and conflicts. And then for other guidelines, it will be very important to work closely with your association, with the society in terms of the policies and procedures, because you are serving as a representative, effectively a leader of that organization. And what you don't want is to have something go so far down the road where your association cannot support the recommendations that your writing group has come up with. So it's much better to have open communication within your organization and be very transparent for any types of conflict resolution. And in general, the vast majority of these are resolved very easily and with very friendly collegiality and collaboration. Thank you.
Following an exhaustive systematic review that clearly is reproducible and clearly documented, evidence and quality assessment tables of the reviewed literature is carefully examined. The guideline writing group convenes in person or perhaps virtually to consider an initial set of recommendations put forth by the chair or co-chair of the group. Alternatively, the guideline content can be subdivided by topic and assigned to various group members, who then propose initial recommendations from within their area to the group as a whole. Each recommendation is evaluated as to, is it appropriate for inclusion within the guideline? Is there supporting quality evidence within the literature based on the systematic review? And is it accurate or should it be revised? A modified Delphi method is used to vet, revise, and approve the recommendations. A 5-point Likert scale, where 1 means strongly disagree, 2 means disagree, et cetera, is used by the group to initially vet potential recommendations. This may be done anonymously in an electronic survey or in person. At each vote, an 80% response rate is required. If greater than 75 of the individuals vote to agree or strongly agree, the recommendation moves to the next level or is simply approved. For recommendations that do not meet the 75% mark, they're either rejected or revised and subject to another vote, or perhaps several votes. Once the recommendations are finalized, a similar process is used to assign the class or strength of each recommendation and the level of evidence present for each statement. As before, an 80% participation rate and a 75% agreement rate must be achieved for each rating. The level of evidence can vary from level A, indicative of multiple high-quality randomized trials, to level C, suggesting limited evidence, such as simple observational trials or expert opinion. The strength of the recommendation may vary from class 1, where the treatment benefits greatly outweigh the risks, to class 3, where no benefit or even harm may result from the intervention. After these ratings are agreed upon, precise wording is employed in rewriting the recommendations to align with the class or strength selected for each recommendation. Group chairs help to resolve group differences in recommendation inclusion or in the assigned class of recommendation or level of evidence. And then finally, once the recommendations are finalized, the writing group provides the supporting evidence for each recommendation to complete the guideline draft.
Before I start my concluding remarks, I want to send a special thank you to all the participants in this guideline for their expertise and their effort. And I want to acknowledge the incredible collaboration that we have had with ASCVTS, EACTS, ESTS, LACES, and the Society of Thoracic Surgeons. Globally, it has been a great collaboration to really help us work together on developing expert guidelines for our specialty. We hope you've enjoyed this first in what we hope will be a series of webinars on guideline development. This webinar has provided the basic information and ground rules for serving on a guideline committee, and we thank you for joining us today. We've stressed the critical importance of equitable representation in writing group selection, thorough scientific review and systematic balanced selection of evidence, autonomous development of recommendations, ratings and voting without influence or conflict of interest, clear explanations of relationships of alternative care options and health outcomes in a transparent and patient-centric manner. Yet there is much, much more to learn. It takes years of such service on many different guidelines to become an expert and avoid the various pitfalls that threaten guideline integrity, fairness, and trust. Yet it's critically important that we dedicate the necessary time and effort to do this well, given the significant ramifications to our patients and our specialty. We invite you to join us for future webinars on more advanced guideline topics, where we will take a more in-depth look at process irregularities and the necessary skills to assure balanced representation of key stakeholders within a writing group, how to mitigate conflict of interest and yet benefit from content expertise, objective review and inclusion of scientific evidence, and the process for escalation of differences within a writing group. We thank you for your attention today, and we hope that you found this helpful. Thank you.